Accumulated fractures occurs where multiple linear fractures radiated from the point of impact. Diagnosis is also dependent on skull radiograph and CT. If the skin is closed and no depression of the bone fragment greater than the thickness of the skull, management is as for the linear skull fractures. With underlying intracranial pathology, for example, epidural hematoma, surgery is considered. Open or free bone fragments are present, then cleansing or debridement is needed. This CT scan shows us the comminuted fracture here. In a depressed skull fracture, the greatest bone depression can occur at the interface of fracture and intact skull and or near the center of the fracture if several fragments are displaced inward. The diagnosis is many patients with depressed skull fracture experience initial loss of consciousness and neurological deficits. Also, the diagnosis of a depressed skull fracture is often indicated on routine skull radiograph by an area of double density because the overlying bone fragments, or by multiple or circular fractures. The full extent and the depth of injuries are rarely appreciated. The full extent and depth of injury are rarely appreciated without CT scan. Physical examination is difficult because of scalp mobility and swelling. This is an intraoperative picture of depressed fracture, and this is the CT scan. Also, a focal neurological deficit from a cortex directed on a depressed skull fracture is occasionally improved by elevation of the bone fragment, presumable by increased local cortical blood flow. Elevation usually produces no neurologic change, implying that impact produces the major cortical damage responsible for the brain deficit. Likewise, the incidence of epilepsy of a depressed skull fracture is determined by the cortical damage at the time of impact. Therefore, the treatment of depressed skull fracture is based not on initiating neurological recovery or preventing epilepsy, but rather than on correcting cosmetic deformation and preventing infection. Exploration is more urgent for a large, closed depressed fracture when the radiology appearance suggests dural laceration, brain penetration, simultaneous frontal sinus fracture, mass effect, or underlying hematoma. A compound depressed fracture is a neurosurgical emergency because of the risk of bacterial infection. The initial surgery is performed within 24 hours and usually within the first 12 hours. Depressed skull fracture over venous sinuses require special handling. Surgical elevation of these fragments may involve massive blood loss if a depressed fragment has been plugging a sinus tear. there are two strategies for measurement. The fracture can be carefully elevated, attempting to gain control of the venous sinuses as soon as possible, preparing for significant transfusion requirements. If the fracture site is not cross-contaminated with foreign material or will not cause a major cosmetic or functional deformity, or not cause intracranial hypertension secondary to sinus occlusion. Such fracture can measured with scalp debridement alone and massive irrigation, followed by CT scan for signs of brain abscess for about 1 year. Fracture of the base of the skull occurs in 3.5 to 24% of head injury patients. Linear fractures in the skull base carry risk of meningitis. The dura is easily torn in basal skull fracture. This places the subarachnoid space in direct contact with the paranasal sinuses or mid-ear structure, providing a pathway for infection. Basal skull fracture are often not detectable with skull X-ray or even CT scan. Basal skull fractures are most frequently diagnosed by clinical findings, making clinical assessment critical. Basal skull fractures are most frequently diagnosed by clinical findings, making clinical assessment skill critical. The base of the skull contains a number of bony channels or filaments that permit the passage of blood vessels and nerves through the bottom of the skull. Clinical findings consistent with basal skull fractures are generally the result of bleeding or CSF leak into one or more of these filaments, or into the sinuses, or due to damage to the nerve that traverses the body canal. For the anterior skull fractures, we can see bilateral periorbital ecchymosis is called Lacour or Penabel, and we may see CSF linolia, and sometimes with the palsy of the first and second cranial nerve, result in anosmia or visual disturbances. For the middle skull base fracture, the patient may present with hematotympany or bladder in the external auditory canal. Sometimes the sometimes fracture of the temporal bones result in the ecchymosis over the mastoid. We also call it battle signs. And we also can see the CSF autolia or linolia. CSF autolia usually occurs through a fracture in the petrous bones with perforation of the tympanic membrane. If the tympanic membrane remains intact, CSF that has gained access to the middle ear can flow through the eustachian tube and present as linoleum. For the posterior fossa, other clinical findings is the palsy of facial nerve. Other clinical manifestations include 7th or 8th nerve palsies, result in the facial palsy, deafness, or tinnitus. For the posterior fossa fracture, we can see the ecchymosis beyond the ear. We also call it battle signs, or impaired gag reflex, This, we can see the fracture of the base. This is the fracture of the skull base. Tender bear or raccoon signs due to the leak of blood from the anterior fossa into the periorbital tissues. Absence of conjunctival injection differentiated fracture from direct eye trauma. Longitudinal or transverse fractures of facial pyramids of temporal bones and the anterior. We also can see the anterior basal skull fracture. This is the battle sign. Post-auricular hematoma. This is the bender. This is the raccoon. This is the battle sign. We can see the fracture here. We can see the fracture here and here. And we also can see the fracture here and the fracture. We can see the fracture here. How a basal skull fracture is managed usually depends on whether a CSF leak is present. A patient with basal skull fracture should lie on the bed. During the observation, time-repeated checks for the linoleum and autolias are made to verify the absence of a CSF leak. Autolia is more likely than linoleum to resolve spontaneously. Because antibiotics are not effective in preventing meningitis and may select for resistant organisms if an infection occurs. Prophylactic antibiotics are not used on a prolonged basis in patients with a basal skull fracture. CSF leak is managed initially by observation of the amount of leakage and monitoring for the signs of infection, change in temperature, mental states, or white blood cell count. Most traumatic CSF leaks resolve spontaneously within the first week. If the leak persistent beyond 5 to 7 days, lumbar taps are performed daily for 3 days, removing 30 to 50 cc of spinal fluid each time. If spinal taps fail to stop the leak, spinal drainage can be used for 72 hours with the patient in 30-degree head-up position. CSF refractory to spinal fluid drainage requires surgical closure. The exit side of the leak is determined the exit side of the leak is determined The exit side of the leak is determined preoperative from a CT scan with both soluble intrathecal contrast, or from a nuclear cystogram with nasal pressures for a small or questionable leak. Next, we'll talk about next traumatic intracranial hematoma. Traumatic intracranial hematoma are localized collection of blood that are directly related to the primary forces. For example, impact, acceleration, and secondary effects. Then traumatic intracranial hematomas are localized. Traumatic intracranial hematomas are localized collection of blood that are directed related to the primary forces, and secondary effects that can play a role in a head injury, such as coagulopathy, alcohol intake, cocaine abuse, hypotension, rupture of aneurysm. Rupture of traumatic intracranial aneurysm and the decompression of the brain following removing Traumatic intracranial hematomas are localized collection of blood that are directly related to the primary forces and the secondary effects. Traumatic intracranial hematomas are localized collection of blood that are directed. Traumatic intracranial hematomas are localized collections of blood that are directed related to primary forces and secondary effects that can play a role in head injury, such as coagulopathy, alcohol intake, cocaine abuse, hypotension, rupture of traumatic intracranial aneurysms, and decompression of the brain following the removal of the hematoma. Epidural hematoma. The epidural hematoma is a collection of blood between the skull and the dural mater. It's caused by a ruptured artery or vein in the epidural space as a result of fracture of the skull at the moment. It's caused by a ruptured artery or vein in the epidural space as a result of a fracture of the skull at the moment of impact. The clot induces because of hydrostatic force of the blood from the ruptured vessels stripping the dura from the bone. The most common scenario is a fracture of the temporal bones causing a tear in the middle meningeal artery. The clinical manifestation occurs as a result of compression and the displace of the brain tissue and is the resulting increase in intracranial pressure. With increasing size of EDH, the patient is more likely to become symptomatic. The neurologic presentation varies according to the size, location, and the time course of hematoma. Most commonly, patients with an acute EDH become symptomatic in less than 24 hours, with 30 to 75% under 12 hours. Rarely, an EDH can enlarge slowly and become symptomatic days after injury. The lucid interval is more commonly seen with EDH, although it can also occur with other intracranial lesions. It refers to the initial brief loss of consciousness because of concussion. With recovery, then it's followed by progressive deterioration of the level of consciousness, often accompanied by hemiplegia. The presentation is variable and patients may be full awake or obtunded when seen in the emergency room. The diagnosis of EDH is established by the diagnosis of an EDH is established by the presence of the typical biconvex lens-shaped hematoma adjacent to the skull, displacing the brain, because the close attachment of the dura to the inner table of the skull prevents the hematoma from spreading. The most common location is the